When I was considering topics for this webinar, I was trying to think about things that I get questions about every single day. And I wanted to give a talk that would be relevant to our clients, but I also think it's really important for our submitters to understand what we do in a diagnostic bacteriology lab and how do you get the most out of your submissions. I want to start by giving a quick disclaimer that this webinar today is not all-encompassing. It's definitely not a course on bacteriology, but it's rather meant to be a high-level overview of what happens to your case as it goes through the lab. So hopefully it'll give you some context and some things to think about when you receive your results and you're trying to put all those pieces together. Okay, to start out, we're going to talk about sample submission and what to include on your sample submission paperwork. Yay, everybody's favorite topic's paperwork, I know, but really important to provide context for what you're submitting. Then once you submit your sample, what happens as that specimen moves through the bacteriology lab? So I'll go through a quick primer on bacteriology cultures and the culture process, and then give you some context on what we do so that you know why you get the results that you do. And then we'll talk a little bit about how to work through a bacteriology case, what kinds of questions you might want to ask yourself once you receive a report. We'll touch on antimicrobial susceptibility testing, discuss the primary methods we use to generate this data, and then I'll leave you with a few thoughts on antimicrobial stewardship. So hopefully we'll have plenty of time at the end to go through questions, and if you make a note about a slide, if you have questions about a particular thing that we've discussed, I'd be happy to revisit those slides at the end. So the first topic I'd like to discuss is sample collection and submission paperwork. So after your physical exam, when you're formulating your differential list and you're deciding on diagnostics and you want to proceed with a culture, things that I generally try to encourage our clients to think about prior to submission include what we're collecting, what's the specimen that we're planning to take? Is that specimen going to be representative of the case and of what you're trying to learn? Are we sampling the right site? Are we collecting at the right point during the disease process? When and how do we plan to take our samples? And is this going to be during a surgery, or is it going to happen in the field where you might not have sterile conditions? What anatomic site are we planning to collect from? Does this require a specific approach to sample collection? Is the site dirty? Something like a visibly dirty patch of skin. Do we need to transport the sample in transport media or consider specific storage conditions? And then, are there regulatory requirements for this testing? Do we need special paperwork? Are there special conditions that need to be met? I'd encourage you to have a plan before you go out to collect your samples. Check our lab website and the submission guide for any special collection or shipping instructions. And if at any time you aren't sure if something's going to work for a culture, please reach out to us at the lab for guidance. We're always willing to help you through the planning steps, and we can help you to make sure that we can utilize the sample when it arrives. So I want to take a minute to talk about some tips for optimizing your sample collection. In general, when you're collecting samples, there are a couple things that tend to make a really big difference when we start processing those samples in the lab. The timing is a big consideration. Have you already started some sort of empirical therapy or treatment at the time of sample collection? Have the owners of the animals been giving something, therapeutically that could inhibit the growth of a bacterial organism? If treatment has been started, you might want to consider taking some time off that treatment. There's different time lengths that should be considered depending on what it is to avoid false negatives on a culture. Additionally, for any samples submitted for culture, we want to avoid cross-contamination. That's super, super, super important. And I know this isn't always possible, but we just want to do our best. So in general, I would not recommend sending swabs from visibly contaminated body surfaces or submitting things like urine or feces that have been collected off the ground. And I know sometimes that's our only option, and we can certainly work with what we have, but just remember that bacteria is absolutely everywhere. And so contamination can significantly confound your clinical culture results. If you do plan to take a swab from a patch of skin that has a visible has visible dirt or contamination or exudate or anything else that might contaminate your sample, you can always use something like a sterile 4x4, give that a little gentle wipe, remove some of that surface contamination, but don't use any sort of antiseptics or soap or anything that's going to inhibit the growth. Tissue is probably one of the most common samples we receive for culture. And in general, we want to collect any post-mortem tissue no later than 4 hours after that animal has died. After about that 4-hour mark, we see a lot of post-mortem invasion from bacterial organisms from the GI tract, which can confound your results. It can make it look like a lot of things are growing when maybe it's just movement of those organisms through the tissue. Sometimes we don't have a choice or we don't know how long an animal has been dead, and that's okay. Again, we'll do our best, but ideally we're talking less than 4 hours after death. Abortions, if you are sampling for the cause of abortion, include placenta if at all possible. And then fecal material, another common sample we receive in the lab. We want to try to collect fresh feces, avoid contact with the soil if possible. Generally, we're not going to need some sort of transport media unless we're culturing for something anaerobic like a Clostridium. And then actual feces are usually a little bit better than fecal swabs. It just gives us more to work with. Urine and other fluids, anytime you collect something that's a fluid sample, more is always better. If you can give us more, we'll have a lot more to work with. And we actually prefer if you don't spin these samples down. We want to avoid sedimenting because this can falsely concentrate our sample and make it a little bit more difficult to interpret. Samples for anaerobic culture, we really are a little bit more picky about these. We'll certainly try to set them up. We'll try to do the best we can with them, but anaerobic organisms are generally fairly fragile organisms. You usually have less than 20 minutes at the normal ambient air before they start to die. So it's really important that we utilize transport media or appropriate sample types in order to get the best results. Remembering that mucosa and the GI tract both have resident anaerobes. So you may see anaerobes come out of your normal culture. We do set up anaerobic plates, but really using that context is important. Things like tissue, bone marrow, or GI tract, as long as it's tied off, are perfectly acceptable to send without transport media. And then a note about trick pouches. We get a fair number of samples for Trichomonas fetus testing. These are usually submitted in trick pouches. We request that you do not refrigerate these or freeze these. Trick are very, very sensitive to cold temperatures, and it will kill them. So we ask that you don't submit them frozen, you don't refrigerate them. If you send them and it's hot time of year and you want to send on an ice pack, that's okay, but we just don't want to make these organisms overly cold. So swabs. Swabs are one of our most common sample types, if not our very most common sample type. If we see lesions that are discrete and grossly visible, we try to swab the edges. This is where bacterial replication is going to be most active. We want to consider the anatomic site. So skin swabs have variable outcomes. Skin is definitely not a sterile site. This goes for ears as well. If you are just taking a general skin swab, you're going to get everything that the animal could be exposed to in the environment. You're going to have normal flora. You potentially have possible pathogens, but these are often very mixed cultures. If you're trying to sample something where you see pustules or abscesses, cystic material, some sort of mass under the skin, some type of surface disinfection plus an FNA can get you a much cleaner sample underneath that skin. But generally, a biopsy may be preferable for tissue and skin, seeing as it gets us a lot deeper, and then we can look for those invading microbes. Swabs should rarely be submitted dry. One of the few exceptions to this might be for fungal culture. Otherwise, we prefer to see swabs submitted in some sort of transport media. A fluid, liquid, Amy's, or Stewart's media is fine. Gel swabs are fine. There are some different culturette tube systems that are sold commercially. Generally, there's a lot of things on the market that are acceptable. We want to avoid viral transport media for just general bacterial culture. This is because this has antibiotics in it that will inhibit the growth of normal bacteria. Usually the exception to this is mycoplasma. So if you're only submitting for a mycoplasma culture and that's all you want, totally fine to use VTM in most cases. Just read the labeling and see what it's labeled for. And then just want to make a note that just remember that not all swab media is suitable for PCR. We frequently receive swabs that are submitted in a gel media, and submitters want both culture and PCR on these. It's not possible for us to do PCR on some of these media because this media will inhibit the PCR. So just keep that in mind if you're looking for additional testing at the time of submission. And then charcoal, this is another type of swab in charcoal media that we usually receive mainly for Taylorella or CEM cultures. This media is used for fastidious organisms, again, not suitable for PCR. So generally, if you're kind of just submitting for overall, you're not sure what's in the sample or what you're looking for, we don't necessarily recommend this as a first line type of media to submit. It's usually for more fastidious organisms. And then I just want to make a quick note about CEM testing. So CEM is contagious equine metritis. We receive these samples for regulatory culture testing. There are a lot of things that need to be included in these submissions. So we have some guidance on our website that goes through what needs to be included on paperwork, what needs to be included on the individual swabs. This is a federal testing program, and so the requirements are not dictated by us. And I know they seem a little bit nitpicky, but this is part of the federal regulatory program, and we kind of have our hands tied when it comes to accepting specimens outside of these regulatory requirements. So if your samples or your paperwork are not in line with what's required, we will be required to no test those samples. So it's really, really important that you know what's required prior to sending in those samples. So either check our website or give us a call. We'll be happy to walk you through it. So what else should be included on submission paperwork? Well, the sample is an obvious thing. That's what we've been talking about. Be as specific as possible. What did you collect? Where is it from? When did you collect it? How old are these samples? How was it collected? All that information is really, really good. Signalment, also very important for us to know what species we're testing from. How old is that animal? Does it have any other pre-existing conditions? Things like that. Duration of condition. Is this an acute problem? Are we talking about something chronic? Some of these things might lead us to set something up a little bit differently depending on how long the condition has been present. Any lesions observed. This is also important information for us, and it might guide us a little bit in our workup. Differentials, really, really important. This kind of ties into history, which I'll go into a little bit more in depth on the next slide. But any current or previous treatments, also super important for us to know if the animal has been on antibiotics, if it was off of antibiotics, when was the last day of administration, did it respond to antibiotics? Those are all really good pieces of information for us to have so that we can tailor your culture appropriately. Any other diagnostics that have been performed? Have you submitted for PCR? Did you do a CBC, chemistry, urinalysis, something that might lead you to believe that we have a bacterial etiology that we're trying to culture for? And then a reference to a previous accession, if it's applicable and available. If you have that reference number, that's really helpful for us to look up in our system, see what we might have done, if this is a reculture, if this is a recheck following therapy. That's just really good information for us to have at the beginning of the culture. And then finally, special instructions. Do you want to consult prior to doing the testing? Do we want to talk about the case? Do you want stepwise testing? Would you prefer that we let you know what we have and then set up an antibiotic susceptibility test after we already have an idea of what's growing in the culture? Or do you just want it regardless? Specific drugs. If you are looking for sensitivities on a specific drug that you would prefer to treat with, we can certainly include that if it's feasible. Again, this is something I'll cover a little bit further down in the presentation, but that's an option sometimes. And then if you're not sure what test to request, that is not a problem. Just go ahead and give us a call. We'll help you through the process and figure out what's going to be the best option for your particular case. So I touched on history a little bit before. Aside from all the important demographic and sample information, I cannot stress enough how important a history is. Just like a thorough history will inform your physical exam and diagnostics and your therapeutic plan in the clinic, a detailed clinical history informs our workup in the lab. So if you can include a history, please do so. And history does guide our workup. It helps us to triage cases. It helps us know what we need to set up. It might help us correlate what we've received. So if your submission paperwork states one thing and has a history of something, but your sample doesn't really match with that, we're going to have a lot easier time thinking, okay, this might not be correct, and we're going to contact you faster if we perceive an issue with the sample. It helps us to determine if we need to do a pre-enrichment step. So we don't do this in all cases, but if we have previous or current antibiotic treatment, if we're looking for a fastidious organism, if we know this is a sterile site that we've collected that might need some sort of pre-enrichment step, we'll go ahead and do that at the front end of the culture rather than delaying things towards the back end. And then it also helps us to know if we need to set up specialized media or use specific conditions for the culture. There are so many different types of selective agar and broth medias, for example, things that enrich mycoplasmas or salmonella or extended incubations for atypical mycobacterium. We have a lot of different conditions that we can use aside from just our general culture process that will help you get the best results possible. This also applies to things like, atmospheric and temperature conditions. So if we have reptile cases, we've had success sometimes incubating those at cooler temperatures. Cold enrichment, if listeria is a differential, or maybe incubating at a higher temperature for Campylobacter. These are all really important information for us to have so that we can make sure we're doing the best possible job to ensure that we're growing something for you. And then finally, the history also gives us an opportunity to offer you adjunctive testing or alternative testing if it might be more appropriate. So for example, if we know we're looking for something that doesn't grow well in culture, but we have a PCR we can offer you, this gives us an opportunity to have that discussion with you prior to when we set up that testing, so that maybe you're not wasting money doing something that's not appropriate or isn't really going to help you. We have a lot of different testing options, and sometimes you don't even know what we might have on hand that we can set up for you. So more history is always better. We're never going to dissuade you from including a history on the submission form. If you can't fit it all in that little box, feel free to attach an extra document or a page or whatever. We're just happy to receive a history. So specific test requests. In general, we will perform the tests that you request, provided that the sample is suitable for that test and that regulatory conditions have been met if applicable. Our submission form serves as our client contract. So if you don't know what you want or need, we can help you decide, but we really do need some sort of idea of where to start. So we have a user guide online. It tells you the test names, the test codes. If you include the test number and the name on the submission form, we know exactly what you want. If it's discrepant between those two, we'll reach out for clarification. But if we can't reach you, we will do our best to determine what needs to be done. You just might have a delay in that case. If you can include all the necessary paperwork for regulatory testing for CEM, Campylobacter, Trichomonas, any of those types of things, please pay attention to the specific instructions for those, because anytime we have missing paperwork for regulatory testing, it will delay the culture. We can't set those up until we have all of the paperwork situated. So now I want to switch gears a little bit and talk about what happens with your specimens once they make it into the bacteriology lab. So this is just a high-level overview of the culture process. General anaerobic and aerobic culture processes are what we do for a vast majority of the culture samples that come into us. So this would be our standard 1089 bacterial identification. It's our culture that we just set up for most everything, unless we're going to require something a little bit more refined. Generally speaking, our samples are plated on a culture media, with or without an enrichment step, depending on what we're looking for. And we use a combination of non-selective media and selective media. So non-selective media is going to be things like blood agar that allow for the growth of all different types of organisms, whereas selective media is going to include different compounds, potentially antibiotics, different things that are going to prevent the growth of some groups of bacteria and select for the growth of others. So we primarily set up one that selects for gram-positive organisms and one that selects for gram-negative organisms. We also generally inoculate a plate for anaerobic conditions. So this will allow us to cast the biggest net possible and just try to grow everything that we possibly can out of that culture. We'll then put it in the incubator at specific conditions for about 24 hours, after which we'll look at the plates for the first time. And so it does take about 12 hours at minimum in some cases with really, really fast growing things, but usually it's about 24 hours before we can first read a plate and say yes or no, we have growth. So at this time, if we have growth on 24-hour plates, we may or may not start subcultures. So taking those individual colony types, putting them on new plates, just trying to clean them up, make sure we can characterize them well. And then generally these plates will go back in the incubator for another 24 hours for a total of 48. And that'll be the next time we read these plates. And usually this is about the time where we can start working up our subcultures. We can start doing additional testing methods to characterize what we have growing. So we use a combination of both classical bacteriology methods and more modern techniques. Classical bacteriology would include other selective medias, special stains, biochemical tests, metabolic tests, things like sugar tests to see what kind of sugars organisms might ferment. We use a lot of different techniques, things like latex agglutination, all kinds of different things. And that's going to give us our initial idea of what we're working with. We will also use more modern techniques for ID, so things like MALDI-TOF, which is mass spectrometry. We basically take in a well-differentiated colony, we will characterize that using some of our classical methods, and then we'll put that in the MALDI-TOF. We'll use mass spec to be able to compare to a library of organisms, and that'll give us some IDs as well as confidence levels. So basically, it'll tell us how confident it is that the signature of that organism matches what's in the computer system. And we can get a relatively good idea for what we're looking at. The MALDI-TOF doesn't always pick up on some things. So for example, alpha streps, alpha hemolytic streptococci, it will sometimes not do a good job speciating those. We'll get to genus level, but maybe not species. Salmonella and Citrobacter, sometimes it has a hard time with. There's some different organisms in Pasteurella ACA that it doesn't like to call between one or another. So there's a lot of different things that we do to make sure that our MALDI ID is also correlating with the different classical methods that we've performed. Sometimes we have to use PCR if we have an in-house PCR method where we can get a little bit more confidence saying, okay, well, our beta streps look very similar. The sugars are kind of too similar to be able to tell with 100% certainty which one it is. We might go ahead and do a PCR to differentiate. And then kind of our backup plan is usually 16S sequencing. So if we're not getting a good ID through classical methods, through MALDI-TOF, through PCR, we might go ahead and send that organism to sequencing and get a definitive ID that way. The bottom line of this slide is that the culture process is a fairly detailed process and requires a lot of time. We're limited by how quickly things grow in culture, and usually we can't speed that growth up very effectively. So we work as quickly as we can, but determining what we have growing can be a complicated process, and it might require a lot of different manual steps. So going back to that first step in the culture process, when we plate the bacteria for isolation from a primary sample, we're generally going to use a quadrant method. So this diagram shows the streak pattern that we typically use. We start with the first quadrant in all the way to the left. It says A, where we spread the original sample back and forth in this first quadrant. We then take our sterile loop and we drag it back and forth through the edge of that first quadrant to streak it into the second quadrant. And we repeat this with the third and fourth quadrants. And so as we progress, we're essentially diluting out that bacterial population so that hopefully we can make discrete colonies of individual types of bacteria grow on that fourth quadrant. Sometimes on reports, we'll note how much growth we have of a specific organism, and we use 1+, 2+, 3+, 4+. And that corresponds with the growth in each of these quadrants. So for example, if you see 1+ on a report, that's going to mean that we only saw growth of an organism in the first quadrant. And this is considered low growth as there wasn't enough of the organism present to achieve growth at the less dense quadrants. On the other hand, 4+ would correspond with very heavy growth as it's still present in the most dilute quadrant. Occasionally, we'll note that there were only a few colonies or state that there was 1 or 2 colonies present, and this would be to exemplify that the growth was almost negligible. So this is something I get a lot of questions about, what does the 1+ or 2+ on my report mean? So after we streak out the bacteria, if we have a pure growth of a single organism, it's going to look something like this. So we evaluate our non-selective augurs as well as those that support growth of either gram-positive or gram-negative organisms. And we're going to evaluate the colonies of bacteria for things like color or pigments produced, as in the top picture here, where you can see the bright red made by the Serratia. We look for texture, size, and overall descriptive characteristics. We might use specific agar that changes color when there are certain metabolites present, like what you see in the bottom left-hand corner, where the agar is changing color due to acid production, and those colonies are appearing a little bit more dark. That's due to hydrogen sulfide production. Or on the right, we might be evaluating for lactate production. And then also in this middle picture, you can kind of see there's a difference in the way those colonies look on the underside of that plate. So the one on the left looks a little more mucoid. All of these are different characteristics that we might use to start differentiating the growth of the bacteria in the culture. So we also look for patterns of hemolysis. So in this picture, you can see the lighter areas where the bacteria has completely hemolyzed the blood in the agar. This is called beta hemolysis. We'll also evaluate for incomplete or alpha hemolysis or double zoning, which is the presence of both alpha and beta hemolysis. And then sometimes the way the bacteria grows on the plate is highly suggestive of its identity. So this is a picture of Proteus and its characteristic swarming morphology. The way it's growing out is kind of in a radially diffuse pattern that will ultimately overgrow the plate, and it might overgrow other organisms underneath. And so if you've ever received a report that states something like, it's a swarmer, this is what that refers to. So these are just some of the first clues as to what we might be growing. And these phenotypical characteristics are going to guide us in our next steps to reach an identification. So sometimes we get a mixed culture, and this is what this looks like. This is actually a picture of an ear culture, a canine ear. We had this in the lab yesterday, and at first glance, it looks like it all might be the same thing. But when you look closer, you can actually see that there's quite a few different tan, cream, white colonies of different sizes. If you hold it up to the light, you can see that some of these colonies have beta hemolysis. So notice that there aren't really any quadrants where you have discrete colonies. So this culture is going to take a while to clean up. We'll work on this over the next couple of days. We'll make subcultures and try to isolate and identify the different organisms present. But every time we sub out a colony, we're waiting about 12 to 24 hours in most cases until new growth on a plate becomes apparent. And sometimes with a particularly dirty culture, we might have to make subs of our subs. The next picture, this one is a lung culture, also was in the lab yesterday. Notice how you have lots of different colony types, including some of that swarming morphology, probably a combination of both Bacillus and Proteus that are swarming in the plate. This would be suggestive of a possible contamination. Since it's a lung culture, it's very possible this animal was dead longer than 4 hours before this was collected. But there are many different colony types, and all of them extend into the fourth quadrant. So this is a good example of what we typically see with older tissue samples when we're getting postmortem invaders. The bottom line is that, cultures with heavy growth of mixed populations may take a significant amount of time to be able to sort out what we're looking for. So if you know what some of the differentials are, we might be able to home in on a specific colony And we can speed that culture up a little bit, but ultimately the utility of describing every single bacteria in a heavy mixed population is generally going to be limited. We do our best to sub out possible pathogens, but you might receive a report that just says 4+ mixed bacterial growth if it looks something like this, and we can't identify a pathogen that's consistently within the clinical context of the case. Or if we feel fairly confident that it's either this is a contaminated culture. This slide might be a little bit repetitive, but some of the things that we want to consider when we see a mixed bacterial culture are whether this is contamination versus a heavy mixed infection. These plates take some time to work through, so they're not quick. This is why we have a variable turnaround time of 2 to 7 days on a typical aerobic culture. Some organisms can overgrow a plate. So things like Bacillus, Proteus, Pseudomonas, they like to take over the entire plate, and growth of these organisms can obscure things underneath. Sometimes it's impossible to get it clean enough to get these overgrowth organisms off the plate and get what's underneath to grow in a way that we can actually identify it. And so in these cases, you might receive mixed bacterial growth or a comment asking what organisms you'd like to have AST performed on, instead of us naming everything on a report and then doing, 5, 10 susceptibility reports. That's going to run up your bill quite a lot. This is especially true in cases with no history. If we don't have a history, or we don't know exactly what we might be looking for, and we can't really work through something that's heavily contaminated, we might just have to put mixed bacterial growth, because it's time prohibitive, it's cost prohibitive. And ultimately, the information you're going to get out of that culture is probably not going to be super helpful in the context of your case. So I do want to take a moment to talk about urine cultures, because these are performed just a little bit differently than our normal cultures. In addition to our non-selective and selective media, we also do a quantitative plate. To quantify the bacteria, we use a calibrated loop, and then we make one streak line down the center of the plate, and then streak back and forth to spread this line of inoculum over the plate. And then we count the number of colonies present and multiply them by a factor that's consistent with our calibrated loop. And that way we can achieve a number that's colony forming units per milliliter of urine. So for this type of culture, fluid urine is preferred, as there's no need to do anything to it. You don't need to spin it down. You don't need to sediment it. You don't need to dilute it or add media or manipulate it in any way prior to submitting. And I'll explain why in a moment, but we read these cultures at 24 and 48 hours. Now, the really important thing about urine cultures, especially in small animals, is that the collection method matters. So there are studies that have established the range of colony forming units per mil of bacteria based on the different sampling methods that correlate with clinical significance and UTIs. So for cysto, significant growth would include any bacteria that grow to a quantity of at least 1,000 CFU per mil. So really any growth on a calibrated plate. And then catheterized samples have significant growth when we see at least 10,000 CFU per mil. Bacterial growth with free catch samples is considered significant if it's over 100,000 CFU per mil. And this is because of the way that free catch urine is going to come into contact with contamination from the GI tract. So keep in mind that this is just a general guideline. It may not apply in certain situations. For example, if an animal was recently given antibiotics, we might see false negatives, and the CFU per mil count might be lower than it would be if it was a significant infection and we had not treated with antibiotics. If an animal has concurrent systemic illness like diabetes, you may see less growth, but it might be significant. This is another plug for why history and sample information is so important to include on a submission form. We can give you more information when we have more information up front. So once you have your bacteriology report in hand, what are some of the things that you could be thinking about in order to discern whether that growth is significant? Was it expected? Were the isolates that we grew on the differential list for this case? Does it make sense in the clinical context of the patient? Is it normal flora, or could it be environmental contamination? Did we isolate an obligate pathogen? Is it correlated with the collection method and the anatomic site of collection? And then does it make sense in the context of other diagnostics? In terms of other diagnostics, does the result correlate with the blood work or a urinalysis? What about imaging? If we can't determine significance, should we work it up further? We have options in some cases for strain typing or toxin typing, and that may be useful in determining whether something is a pathogen versus something that's just incidental. Now, what if nothing grew? What now? Well, the time elapsed between sampling and submission might be important. Was the sample old? Could that have given you a false negative result? Did we have transport media on board? Did it support the growth of the organism in transport to the lab? Were there storage conditions we could have done better with? Was there any previous or current antimicrobial administration that might have inhibited the growth on a plate? Could it have been due to the method of collection? Did we get a representative sample? Was this the wrong sample type? For example, tissue is often needed to get good growth of rapidly growing mycobacteria rather than a skin swab. And then some bacteria just isn't viable in culture. Sometimes it just dies in transit, or it isn't supported on those plates. Some bacteria can't be cultured in typical culture systems. So things like leptospira, tuberculous mycobacteria, Coxiella, chlamydia, some mycoplasmas. These require very specific culture methods. Resampling versus different types of testing. We might need to consider other things that we could do to get you a diagnostic answer that doesn't include typical culture. All right, once we have a bacteriology report, we have IDs of organisms of interest, and we've determined their significance. Generally, the next step is going to be a request for performing antimicrobial susceptibility testing, or AST. So I do want to start this section by stating that AST is an incredibly complicated and nuanced topic. Microbiologists spend their entire careers studying different mechanisms of resistance, and people debate and discuss changes to susceptibility criteria constantly. So here's your reminder that this is, once again, a high-level overview and not all-encompassing. Also, while we as the laboratory provide susceptibility data, please be aware that the AST report is not in and of itself a recommendation of what drugs you should use to treat. As the clinician with the VCPR, you're the one responsible for deciding which drug might be the most appropriate to use in a certain situation. We are happy to help you interpret your report. We're happy to guide you through it, explain limitations, go through different issues you might have with one drug versus another. But ultimately, you need to use your clinical judgment when you're looking at an AST report and determine what you want to treat with. So the goals overall for AST is to determine which antibiotics might be options for treatment and to monitor trends in resistance patterns. There are some limitations with AST. So one of them is that it relies on phenotypic characteristics in vitro. We're cultivating live organisms in vitro, and then we're subjecting them to these drugs. And in vivo, the results may not exactly mirror the results that we're seeing in vitro. These methods take time. Some organisms are difficult to test. Some of them don't like to grow in our culture or our MIC system. Some of them don't like to grow well on the Kirby-Bauer plates. And results may depend a little bit on the lab and the method that's being performed. You can get a little bit of variability between labs because there are some differences in the way that different labs perform these different methods. Most labs only have certain antimicrobials on hand, so we might be limited in the types of drugs or the individual drugs that we can test. And then finally, extrapolations might be necessary in veterinary medicine. So we do our best to use specific criteria that pertains to the host species from which the samples originated, but sometimes we do have to use human susceptibility breakpoints or generalized breakpoints to get you some results. And that does come with caveats regarding the efficacy of drugs that are reported as susceptible. So now I want to briefly go over two of the main methods that we use for antimicrobial susceptibility testing. in the veterinary diagnostic lab. So Kirby-Bauer disc diffusion is a mostly manual method where we take a well-isolated subculture of bacteria that we've at least identified to a genus level, and we grow it up to a high enough quantity that we can dilute it to a specific density in a broth. We spread this standardized growth on a plate, and we add antibiotic impregnated discs to the surface of the inoculated agar plate. And these discs are going to allow for diffusion of the antibiotic drug through the agar in all different directions. After incubation, we measure the zone of inhibition around that disc, which tells us how effective that drug was at inhibiting the growth of that organism. Once we have a measurement, we'll take that zone size in millimeters and we compare it to establish breakpoints for interpretation of susceptibility. I'll cover that a little bit more in a moment. The other primary method we use for determining susceptibility of an organism is minimum inhibitory concentration, or MIC. And this is usually our preferred default method, mostly because it's a little bit more automated than Kirby-Bauer. But some organisms don't grow well in this system, and for some things we don't have MIC breakpoints. So it's important to note that the method of AST that we choose for an organism is usually dependent upon what organism we're growing and what methods are available for that particular bacteria. When we use either Kirby-Bauer or MIC, we'll typically use MIC so that we can move through the workflow a little bit faster and hopefully get those results out to you a little faster. This is a basic diagram showing the idea of what we're measuring when we set up MIC plates. In this diagram, we have a 96-well plate that has standard concentrations of a drug that go from higher concentrations to lower concentrations along a gradient as we move across the plate from left to right. The dilutions are usually in micrograms per milliliter, and each of the rows corresponds with a different compound. We then take a characterized isolate that we've grown, we dilute this organism to a standard density called a McFarland, and then we inoculate the same amount of bacterial suspension into each well. We then read the plates and we look for bacterial growth in each well, and the lowest concentration of the drug that inhibits the growth of bacteria is called the MIC. Now, another comment I want to make is that the MIC value itself is not a drug dosage recommendation for in vivo use. It's an in vitro dilution of a drug that's used to determine whether it will inhibit the specific bacteria, but it's not the drug concentration that you're trying to achieve in the animal that you're treating. So in some cases, the MIC value will actually correlate with a drug dosage or range, but that drug dose you administer to a patient is going to depend on a lot of different pharmacokinetic and pharmacodynamic factors. We do provide this value for discussion purposes, and some labs actually choose to omit it entirely from their reports. But we have a good number of exotic and wildlife submissions for which there are no published breakpoints. And so in these cases, having the MIC value might be helpful for a specialist in determining a treatment regimen based on published literature. But within the clinic and for most of our susceptibilities, you're going to want to focus more on the interpretation itself rather than the numerical value. In reality, our plates are a little bit more complicated than the previous slide. This is a diagram of one of the plates that we use. We purchase preloaded commercially available plates that include a variety of antibiotics appropriate for the use of various classes of host. We don't have custom plates, so we don't have good options for creating what people commonly request as extended profiles. For example, we have plates for food animals, which include drugs that have been approved for use in cattle. We have equine plates, we have companion animal plates. And some of these plates are specifically for use with one type of bacteria or another. I do want to mention at this time, we don't have plates for fungi or yeast, and there are currently no approved breakpoints for use in veterinary medicine. But drawing your attention back to the diagram, this is an example of one of our companion animal plates. And you can see that we have a lot of different drugs of varying concentrations. Some drugs might have multiple dilution with like penicillin. This one has 8 dilutions, and some might have a lot fewer, like rifampin. In this case, it only has 2. The number of dilutions and which dilutions we have on a plate will impact what we can determine susceptibility for or if we don't have it. Ultimately, this is just to illustrate that the plates we use in the lab do have limitations, and customizing them is difficult and not always possible. So susceptibility criteria. We used published susceptibility criteria that's been set by the Clinical and Laboratory Standards Institute, or CLSI, to determine whether something is susceptible. The image on the right is a screenshot from one of our CLSI manuals, and I just want to impress upon you how complicated these determinations can sometimes be. So we use host species, bacterial family or genus of species, the body system of that it was collected from, the type of drug. All of these factors are included in the determination of whether something is susceptible. We might selectively report drugs if we don't have an interpretation for something, or if we don't have an appropriate drug for the class of animals. So like with food animal species, some drugs are not appropriate to use in these animals. We will omit those from the report if we can. If we have nitrofurantoin in a panel, we're only going to report those for urinary cultures because it's only bioactive in the urine. We might also have intrinsic resistance or no interpretations. So all of these things we have to take into consideration when we're putting your report out, whether it's going to be useful for you. And then we'll compare what we have in these CLSI guidelines to determine whether we're going to run a Kirby-Bauer or an MIC, or maybe sometimes both, to get you the combination of drugs that you need. Not everything has interpretations for KB or MIC or both. And sometimes we might have to do additional panels or methods to get certain other drugs, especially if you've requested a specific one, but not every organism has interpretations for every type of drug. The susceptibility criteria is based on consensus recommendations and CLSI guidelines for both MICs and Kirby-Bauers. We have 3 options generally on our reports: susceptible, intermediate, and resistant. And I've taken these definitions right from CLSI word for word. So susceptible means that the breakpoint implies the isolates are inhibited by achievable concentrations of an agent, and that these agents will have clinical efficacy. For MIC, it means that the value must be at or below the defined breakpoint. And for Kirby-Bauer, it means the zone size must be at or above this breakpoint. Intermediate means that isolates with MIC values or zone breakpoints in this category, the response to antibiotics might be lower, or it might require unachievable blood or tissue levels of antibiotics to be effective. Resistant is characterized by a MIC or zone breakpoint that implies that the isolate will not be inhibited by achievable concentrations of antibiotics. And so clinical efficacy is not likely or hasn't been reliably shown in treatment studies. There is a class called susceptible dose dependent. This is a category that has not been previously included in TBMDL reports. We're currently looking at incorporating some of these recommendations in our susceptibility reports, so stay tuned for that. But this implies the susceptibility of an isolate depends on a dosage regimen used. So for example, higher doses, more frequent doses, extended infusions. The dosage regimen results in higher drug exposure than that achieved with the dose that was used to establish the susceptible breakpoint. We're still looking at the best way to include these interpretive criteria in the report, but hopefully the idea is it would give you a little bit more information for what types of ranges might be appropriate to use. Note that the MIC value, again, in vitro is not the same as the dosage of the drug. So the MIC value may correlate with a drug dosage or a range that was utilized in the study for the breakpoint, but it's not necessarily going to be the exact same thing. And then I also briefly want to touch on the concept of intrinsic resistance. This is resistance to drugs or drug classes that will be exhibited by certain groups of bacteria regardless of in vitro susceptibility upon testing. So basically, some bacteria are just inherently resistant to certain drugs or drug classes. And historically, we tend to leave these off of the reports, which can be frustrating for clients when they don't see entire classes of antimicrobials. But it's important to understand that even if we test them, intrinsically resistant drugs will not work in vivo, so there's no possible interpretation other than resistant. Common examples of intrinsic resistance that we see in veterinary medicine every day include Proteus, Enterococcus, many different species, and Pseudomonas. These are common bugs that have lots of different intrinsic resistance patterns, and so often your susceptibility reports are going to be a little bit sparse. So when do we typically perform sensitivities? Well, when they're requested by the practitioner. We tend to perform them on obligate pathogens or predominantly opportunistic pathogens and organisms that correlate with the disease process and history. Or if it correlates with histopathology, cytology, PCR, other diagnostics that may have already been performed, and we have that information going into the culture. When do we not perform sensitivities? Usually when it's a mixed culture with no predominant colony type. If growth seems like normal flora, like enterics or coagulase negative staph on the skin, we might not do a sensitivity right off the bat. If growth is clearly contamination, we will not do a sensitivity on that. If the isolate is not consistent with the clinical history, it might not be worth spending your money to do a sensitivity on this. And if the isolate does not readily subculture or can't be grown in the MIC system, we will not be able to perform an MIC. If we have limited interpretive criteria for an organism like Truparella, you may get a comment on the report stating that. And if we cannot do it for regulatory purposes, so something like Brucella, we'll also not be able to include that on a report regardless of whether it was requested. If we can recommend susceptibility without performing AST, one good example of this is beta hemolytic streptococci, which are universally susceptible to beta lactams. We might give you that kind of a comment on a report instead of doing the full susceptibility. And that's to encourage you to use those first-line drugs. And then antibiotic or anaerobic organisms and yeast, like I mentioned before, we don't have the ability to perform those. So should I treat with antibiotics? You have to determine whether antimicrobials are truly necessary. There are certain conditions in which, historically antibiotics were something that was reached for right off the bat. I think that we have enough evidence to show that maybe that's not something we want to do anymore. A good example of that is diarrhea in small animals. We want to consider the GI microbiome. If we're treating with antibiotics, we're probably going to cause more damage. Strangles in horses. Antibiotics are not always necessary. Timing's really crucial. The antibiotic administration may actually prolong the disease, and you have to determine whether you're looking at a complicated versus uncomplicated case and whether you want to weigh the use of antimicrobials. Caseous lymphadenitis or pigeon fever. Antimicrobials are not usually effective at getting through to these encapsulated abscesses, so antibiotics might not be necessary in these cases. It's important to think about, do you need systemic therapy versus can you use something topical or local or an antiseptic that might be a viable option instead of reaching for a systemic antibiotic? And if necessary, do choose first-line drug options. We want to reserve those quote-unquote big guns for special cases, even if it's a little more convenient. Certainly there might be things that are susceptible on a report, and we might have those on hand, might want to use them, but maybe there's a better option, a better evidence-driven option. So at this point, I just want to take a moment to introduce the concept of antimicrobial stewardship. The WHO defines antimicrobial stewardship as a systematic approach to educate and support healthcare professionals to follow evidence-based guidelines for prescribing and administering antimicrobials. This topic has been so incredibly important lately. Antimicrobial resistance has become one of the most leading causes of death globally. And one study estimated that almost 5 million deaths in 2019 were attributed to infections with drug-resistant bacteria. And there are more studies coming out all the time that stress that, this isn't a problem that's just going to go away overnight. We don't know the true burden of antimicrobial resistance on veterinary medicine and animal health. However, I have seen some recent data that's really promising, and it shows that when we promote antimicrobial stewardship, we have the ability to reduce selection for drug-resistant bacteria. And this in turn improves our options for antimicrobial treatment in our patients. So what can we do to promote antimicrobial stewardship? I'm sure most veterinarians at this point have received an AST report with really scary few options. We play an incredibly important role in antimicrobial stewardship and ensuring that we have these options for treating patients well into the future. So what exactly can we do? Well, I'd encourage you to continue to request antimicrobial susceptibility testing from accredited laboratories. I say accredited labs because this gives the best chance of utilizing the same methods so that AST data is comparable over time. Most accredited labs, including TVMDL, will participate in some combination of national AMR surveillance programs. And this data is crucial to monitoring the trends in resistance over time and further fine-tuning the guidelines and recommendations for use. Now, I'll also note that we as a lab do try our best to promote antimicrobial stewardship, which is why sometimes we don't initially perform AST testing on something, even if it was initially requested. You might receive a comment explaining why AST wasn't performed, but please understand this isn't because we don't want to do something you've requested. It's simply because we want to ensure that we're not encouraging the use of antimicrobials if they may not be necessary. So use antibiotics only when necessary. Do your best to limit empirical therapy if you can. If you can submit for AST, please do so and try to use only first-line drugs and most appropriate therapies rather than reaching for what might be more convenient. I really like this concept that's used in the nursing world. It's called the 5 rights. And you want to consider whether you're using the right drug at the right time, at the right dose for the right duration, and administering it via the right route. Consider whether there are evidence-based alternatives for treatment that don't include antibiotics. A great place to find information is the ACVIM. They periodically publish consensus statements and do a great job explaining evidence-based therapies for a variety of diseases. You want to continue monitoring and reevaluating periodically to ensure that your treatment plan is effective. Use infection control practices in your clinic, the use of PPE, isolation when necessary, disinfection, and using correct disinfection protocols according to the labeling instructions to ensure that you have adequate contact time and efficacy. And then client education. This is one of the most important things that you can do in your practice. Educate your clients about antimicrobial use and resistance and the overuse of antibiotics. Take the time to explain why this is so important to the future of medicine. Make sure they understand why following drug administration directions is so important. Also, something that's overlooked often is make sure to discuss proper disposal of antimicrobials to keep them out of the environment. At this point, I'm going to go ahead and wrap this up for today. I've added our general contact information to this slide. I also want to let you know, if you haven't already heard, that we have recently welcomed our new bacteriology section head, Dr. Bibiana Petri de Silveira. If you have specific questions about bacteriology cases in the future, please don't hesitate to reach out, and either Dr. Silveira or myself will be happy to assist you. And otherwise, if you have any questions about today's presentation, I'd be happy to answer them. I think we have a very short amount of time to do that. I'm not seeing any questions in the chat, Mallory.
Yeah, I don't see any either, Dr. Schwarz. So I think you did a great job of covering everything. But as you mentioned, if anyone has any questions, please feel free to reach out to Dr. Schwarz or Dr. Silveira or anyone else here at TVMDL, and we can certainly assist you with those questions. Other than that, we have 2 more webinars scheduled for this year. One in July, hosted by one of our pathologists in Canyon, Dr. Emily Hoskins, who's going to cover kind of the context behind what a pathologist needs when going through those cases. And then our final webinar will be in October and hosted by Dr. Alexis Thompson, and she will be presenting over bovine respiratory disease. So we hope to see y'all for those last 2. Other than that, thank y'all for joining us today.